Welcome back, sports medicine fans, to episode 86, part 2 with Dr. Taylor Goldberg. I definitely know you all enjoyed part 1 because we got lots of listens, lots of good feedback. So I know you're going to enjoy part 2. It skipped to 22 minutes and about 30 or 40 seconds. If you don't want to listen to Kelly and I talk about a couple of things, which were city to surf, injury of the week, a proximal BSI diagnosed by a podiatrist, what's going on there, Adam Meakin's leaving the profession, which was the post of the week, and the person of the week was the skeptical physio. Enjoy, guys, and have a good week. You deserve it.
Welcome back to the Sports Medicine Project Part 2 with Dr. Taylor Goldberg. I hope you guys all enjoyed Part 1. This is the back end of it coming your way. A very insightful podcast, I thought. A topic that covers something that we probably see parts of in lots of different patients. So therefore you can apply it, I would say, almost every day in some way. We ran City to Surf today, and it was so cool. There was like the most amount of people I've ever seen in a running event in that small space. And I just had so much excitement that the running community is just so large and everyone's so happy to be running and enjoying a sport, a mutual hobby. I thought it was, a really good event. Did you enjoy it?
Yeah, I had lots of fun. And I had really good week. I listened to Taylor Goldberg's podcast on the Monday morning on the drive down to uni again, and I had my little notepad out. Couldn't write anything down, but I was like writing down the time to go back and then rehash some of those education points. That was an awesome episode.
While you were driving, you were writing in a notepad.
What I would do is have my diary there, and it'd say 26:48, and I'd just quickly write that because I want to go back to it and look for that little educational piece that she gave. She speaks so well, and she really, she has the experience of seeing people that are hypermobile all the time. She doesn't do it in person at this current point in time. She does most of it online now, but just speaking with people, I feel as though if you can do it online, your education has to be really top notch because you kind of have to make up for what you can't with the hands-on, but I guess it's what people value.
Yeah, I think that would be a topic that would be really well applied in the online space, particularly, well, I don't know.
I guess so. If people are seeing her, I think if they're seeing anyone online and they're saying, hey, I've been diagnosed with this EDS, so I'm clinically hypermobile, what can I do about it? What should my strength look like? Why do I keep getting fatigue? I guess you can answer all those things and to why.
Yeah, definitely.
Yeah,
we do talk about manual therapy a little bit, and it's when there is a place for it in the hypermobile person. But I would say that would be a smaller component a very small component of the overall rehab picture. So the online space would be definitely suitable for it. Yeah,
definitely. And back to your other question, City to Surf was great. Lots of fun. So lots of kinesio tape. Lots of people wearing the blue tape. You probably didn't see it because you were really far behind me for most of it. So
as if I was 1 minute behind you.
Yeah, I don't really remember much of it. I just remember you were with me and then you weren't with me. It was around the hill. Is kind of when you dropped
took off on the hill. But
I didn't take off at all. No. Go back. No. I didn't take off at all. I kept a consistent pace, and you just kind of like a truck going up the hill. You go, and you just went down and down. But then you kind of.
I ran sub 20 at parkrun yesterday, though.
Yeah, you did run pretty quick. You did. That was a good.
When was the last time you ran sub 20 at parkrun? Huh?
Oh, I did it a very long time ago.
Yeah. You can barely even claim it anymore.
I know, I probably couldn't go run that quick anymore, but I did claim that one. It's like the claim in the sub 90 half marathon. There's no way in hell I could run that now. Or I even dream of running that now.
That was 12 months ago because the Lake Mac half marathon is in next weekend or 2 weeks or something.
I didn't tell you this today. I didn't tell you this on purpose because I was waiting for the podcast because I wanted to get your initial reaction.
Hit me.
I saw this guy running today. And listen, we talk a lot about tissue capacity and resilience and anatomy and biomechanics being contextual. This guy's left foot, I'm telling you, his medial malleoli was on the ground. I saw it, and I see these things all the time because if you're running or you're walking, you just look at someone's foot or the way that they move because I do it every day, 5 days a week, and I talk to people about it all the time, and I teach about it all the time. But I'd never had the urge to. I looked away, looked back, and I was like, oh,
and he was running?
Yeah, so I'm like, do I need...
I think that's some good tissue capacity right there if he's running.
Yeah, but it was really asymmetrical. Not to say that that's... But there has to be... We can't say that it doesn't matter, because this guy, I'm assuming,
was he limping?
No, but he had a...
Then you don't need to intervene.
Yeah, I don't know. I don't need to intervene. I'm not saying that I ever need to, but I just have never had the urge to. It was just
what's the
instinct
long-term implications of being on your medial malleolus?
I thought for a second, maybe his shoe has worn out, or because he had like this knee valgus and hip drop so much because of his foot position. So it wasn't anything else. It was almost like that limb was 4 centimeters shorter, and it was just rolling in to become functionally longer. It was crazy, or vice versa, whichever way.
Older or younger?
Don't know what he looks like. Don't know anything about his appearance.
Couldn't take the eyes off the
other
ankle.
than he had a pair of black Asics that look like GT 2000s. That's what they look like, and it was just crazy. I couldn't believe how much, but yeah, he was.
Well, if you're out there,
yeah, he's obviously running City Surf. He's strong, but yeah, it's. I remember one of my old uni educators telling me he went up to someone in the supermarket who had he had identified as a foot drop, and explained that you can have things like a Ritchie brace or an AFO to help out, or even a foot up brace, and it. I don't really know how he say it went down. I think he said it went okay, but yeah, I'd never had that urge in my life until that point today, and obviously didn't stop and say anything. I just ran past and
when I used to run with Nikki and Rachel every Thursday morning, we'd do the same run and we'd see the same man walking every single time. And I think he was more on his lateral malleolus on one side, but like proper, like it was big asymmetry. And Nikki and I used to always laugh at the asymmetry. And then one day we ran past and he had some new shoes on, and they really straightened him up, and he looked pretty good actually. So they did.
You sound horrible.
They put him right back
really
into alignment.
Yeah. I saw a guy in the not in my private practice clinic, in the student clinic. He had a really high pitched arch, a really laterally deviated subtalar joint, real lateral loader, and someone had put him in a pair of Kayanos, and he was getting all this lateral leg pain. I mean, you take the Kayanos out and still he had this foot type, but this is just pushing him laterally, and then the foam had compressed, and like that is such a simple thing to get right, and that can be something pretty easy.
I feel like it's tricky. This is something I've said to you before. I think it would be so useful for physios in particular, because it's not something that we spend heaps of time on in talking about, like footwear as its therapeutic use, because you think of the Asics Gel Kayano as like a stability shoe, and so if someone sees a foot type that requires some sort of like frontal plane stability, that's sort of the first thing that you kind of think to go to, because you don't really like. I would say that it's not common knowledge that it's actually going to do the reverse of that. Do you know what I mean?
Yeah, but to your point, in the context of this, it wasn't another health professional or it was a retailer. He'd gone to a retail place. I can't remember the place, and they had put him in that, which, I mean, it seems pretty obvious if you're working in retail and you see someone with a foot type like that, who will also have pain on the outside. Whether or not this person mentioned that I don't know the answer to that, but you would think not to put them in a shoe with support on the inside. I
think that's another reason why it's so good to develop a good relationship with your local shoe store. We've got a really good relationship with the local shoe store in Newcastle, and I trust sending anyone there, and trust that they'll come back with the right thing. So I think that's worthwhile, having a good relationship with whoever that might be.
I think it's hard for those retailers because they, purely from an economical store standpoint, and this is the same for all retailers, they're only limited by what shoes they can carry. So I might think this shoe is best, or you've had success with this shoe, great, go and try that on. Oh, they don't have the size or the colour. So that does make it difficult as well. And it's hard because you want someone to try it on. But I've been, people ask if I just buy it online, is it the same shoe, is it the same model? And I think having somewhat of an understanding, because people can just have a better choice from a colour or style that they like compared to some of the other places that might not have it. Like you might go in and go, oh, I've got to have a size 10 Hoka Bondi, and they don't have it, and that's the shoe you really want and like and need, and you've had before, it can be sometimes challenging. Yeah, I'll stop talking about shoes. Shoes are important, but probably not as important as what we...
But that is one of the greater things about doing a race, is you just get to look at everyone's shoes and what they're wearing.
Well, we started in the blue pack, so we didn't really see... There weren't too many super shoes getting around in our pack. Because we did what?
It was a big pack.
Yeah, we did an hour before Studio to Surf, and then 30 minutes after. You bought my bib later, so I didn't get to start in what we would assume would be like the 4:30 to 5:30. We were in like the 6 to 6:30, so it was a lot of weaving.
A lot of weaving. It was a good multi-directional stress.
Yeah, it was. Right, let's get into segments of the week, injury of the week, post of the week, and what's the other one? Injury of the week, post of the week, and person of the week. That's right. So you want to talk about the post of the week, which I'm sure a lot of the listeners
have seen this one pop up. It was on Twitter, and it was by Adam Meekins.
Well, it's been everywhere. Twitter,
I don't think it was on Instagram.
Yeah.
I didn't see it on there.
Yeah.
I had to look it up because Dave mentioned it to me at work, so I used your Twitter to look it up. But Adam Meekins, I think a lot of you are aware, has been going through some of the court stuff about some people calling him out for making some criticisms on, or what, I don't know
mostly
really what that was about. Swearing.
Yeah.
Oh, yeah, okay.
And amongst other things.
Yeah.
And you can head to the post to read. It's got everything that he's that they're assuming that he's done.
Yeah. But I guess the sort of final stage of that is that Adam Meekins has decided to not be a physio anymore.
Yeah.
He's decided to make a career change or profession change. You can read the post for the exact details, but it's really sad. I really think he was a very monumental person in my earlier part of my career. I remember learning from a lot of the sort of mentors around me, but then also listening to his podcast that would often sort of challenge some of those ideas that were being taught to me face to face in the clinic that I was working at. And I think he really helped me in being able to sort of remain skeptical about a lot of the information that you learn and that you hear. And I think I still try and carry that sort of thought process through. And I think it's really valuable to have had a key figure like that in our profession that's bringing out a lot of the claims that people make. And I think it's really sad.
Yeah, it's funny. See, I get something completely different from him. I mean, I have got something completely different from him. His ability to really just go in on people and not to go in on people, go in on their posts and the information that they share and blatantly call out things that aren't evidence-based. And not to say that they're wrong, but just saying we don't know that, you're making this really dogmatic statement or you're making this claim with all this certainty and it's not true. Where you're getting this evidence from? I just thought that was interesting, and I thought that was really cool. It keeps everyone
very honest. Well, tries to. That's the idea of it. Yeah, I think for me, it was more how he helped shape my clinical career. So how I'm thinking about treating patients and things like that. It sounds like you're thinking about it more from a social media perspective.
Yeah, well, in some sense, it makes me work harder because I've seen him call out posts and ideas. And to be able to do that, you have to have done the work. You have to be across the topic, generally speaking. So if someone makes a claim about running injuries, if I'm going to call that out, I have to be across running injuries. And I think that was something that was motivating for me. It almost, not to say that you should do the work to then be able to call people out and say, I know everything there is to know about it, but it makes you want to learn about the topic because you're speaking about it. And when you see a post and you just imagine your patient seeing, someone in your family seeing it, or something that it is harder on your profession, I just thought that was something that he'd really pioneered.
Yeah.
Was the first person I had followed.
Different very useful areas that he has helped shape within our careers. And it's sad. He did say that he's not completely abandoning the space, so I'm not sure what he's going to continue to do, but I guess watch this space.
Yeah, and we don't know Adam personally at all. Like, we've had maybe a couple of messages here and there on Instagram about a post or something like that. So
I wonder if you'll still run courses and things. Do you need to be registered, like a registered physio, to be able to still run courses and things like that?
I don't know. I imagine maybe the content would fall under the regulation of, say, our version is APRA. So like if you're giving medical advice, you have to be registered with a medical board, maybe, or something like that. I don't know. But yeah, it's interesting, and it's sad because one thing that makes me scared and worried that if something does happen and he gets deregistered or he leaves, what does that mean for everybody else that perhaps does call out this information? So like Squat U University is an example. And let's say everything that they post is horrible, but some of their posts are just blatantly wrong, not evidence-based, catastrophizing, kinesiophobia, all that stuff. And if there is nobody to ever call that stuff out, does that just continue to grow, and then that becomes the norm?
And then the other side of it too, which I understand, as Adam posted in his post, that like it was quite mentally really draining, quite fatiguing, having that sort of burden and load on him of all these people calling him out constantly and having to go to court and things like that. But in a way, like they've kind of won now as well. Like that's the other
what do you
part
think?
Of it.
I mean, I wonder. I guess the goal is to try and help the profession and perhaps put us as physios and podiatrists and healthcare providers on this bit of a pedestal of like, we're the experts, we help people, this is how we help people. You wonder how much, is that the best way to do it? Calling out people on social media, speaking behind videos, is there better ways to do it? Is that the right way to do it? How much motivation is there from, I'm actually going to call out this person for shitty stuff, or I'm going to call them out because we know this is the best way to grow a social media? Because people like arguments, people like debate, people like misinformation. If I post a video with a video of someone behind me, that spreads faster. It gets more views, more likes, and more comments. So not to question his motivation at all, but I mean, you have to wonder sometimes, of course, with anything on social media. I mean, I've definitely fallen victim to it as well.
I guess it depends on what your goal is. Like for someone like you, I mean, your goal is to help more clinicians almost and to spread the word to a greater audience on how to be a better clinician, whereas I feel like my more sort of intimate goal would be to help the person in front of me and help the patients and develop good relationships around the Newcastle community. But so I definitely don't feel like I want to or have a place in needing to call out social media posts. That's just not in line with what I value as being a physiotherapist. But maybe for someone like yourself it is. I don't know.
Yeah, I've called out a couple. I don't do it as much as what I thought I would, and I can see how it is so easy to do, because all you have to do is say, post behind you, speak in the video, or share someone's story and say, this is crap, this is not right, or speak about the evidence. And I never wanted our page to be about that. I want it to be like, they post stuff about evidence and information and their own clinical stories and case studies, not, that's that page that posts, that calls out other people's stuff and just does talking videos.
I think the safest way to do it is just to create good quality content yourself and just let the idiots continue to do what they want to do, and you just continue to do a good job within your space or with the audience that follows you. Yeah.
But the side to it is, so let's say you want to reach 100,000 people, the more likely way to do that is to have controversy. And we can see that from political news, economical news, misinformation.
But you can still do that in a video yourself.
Yeah, of course. I'm not trying to argue for that, but I just think I can see sometimes the other side to it. Yeah. What about,
I said the injury of the week last time. You're up today.
Yeah. I'm up for the injury of the week. So the injury of the week was a proximal bone stress injury. So, and you're thinking, why is Blake talking about this? He's a podiatrist. This person had been referred for something unrelated, some foot pain. Far out. Not feeling too great at the moment. Referred for some foot pain. Like training for a marathon. And I always ask the question, how does everything else feel? Knees and shins and hip and back and things like that. Not because I'm going to be the one treating them. One, it can sometimes be a a good way to refer out to someone else, like physio or sports doc, if they're struggling with that. 2, perhaps I might need to assess it. And 3, it may affect the treatment that I'm actually going to implement at a foot and ankle level. Like if someone has really raging knee pain and I'm looking at doing a return to run program,
you need to be considerate of that.
Yeah, for their foot, I need to be considerate of what's going on there. And I need to rule out or be confident there isn't something nasty, has someone assess it, that kind of thing. So this person had mentioned they'd had some more proximal pain, wasn't the knee, and based off some testing we did for the lower limb and also for the more proximal lower limb, there was enough evidence there to discuss with a referrer about having a scan, and it ended up coming back that it was a positive BSI. And it was a good reflection point to think, as podiatrists, legally, and we teach people to assess all the way up to the hip, and it's important to be able to do that, not because you're going to be managing and treating it every single day, but for that one black swan case where someone hasn't seen this and might not have seen someone else or might not have mentioned it, and you're the first one to see this, you need to be able to have a bit of an understanding of all the other things that potentially could go on. A BSI, a fracture, is it just patellofemoral pain, is it glute pain, or is it like, this is actually really serious, I need to get this needs to be sorted before I look at treating what I was going to treat.
Yeah, like imagine if that was I guess that is a high risk area, and imagine if you hadn't asked the question of how the rest of the body is feeling, and then you continued to progress the ankle and you started to do some jumping, hopping, lots of running, a higher volume of running, and that did progress into something like a full-blown stress fracture. That could have been a really bad scenario. Well, that would have definitely been a really bad scenario for that person. So definitely good pickup and really good screening questions.
Yeah. It was just it just reinforced why we asked those questions, and it reinforced why you need time in the subjective. Like, we have an hour for our initials, and they'd mentioned some things more proximal, and I ended up asking probably the same amount of questions about that, probing deeper, and then testing that as well. So luckily I had the time to go through that. And then for an educational piece at the end, it's going to be a little bit odd going, you're a podiatrist, why are you telling me this? Why should I go and do this? And you need to be able to explain that through, plus also what you're actually treating, which is the foot and the ankle.
That's good.
Now, I got a person of the week to follow. You didn't have anyone this week. I've got someone. Their name on Instagram is Skeptical Physio. I'm sure a lot of people already follow this person, but does some really interesting posts that are just really get you thinking, like the truth about spinal manipulation, the knee is not for bending, diagnosis human, the dictatorship of good intentions, just some really cool stuff. It's all evidence-based, and there's some really good comments and discussion on there. So it's pretty cool. So Skeptical Physio, they are, it doesn't say where they're from, and I actually don't know who it is, but they're really good.
I've actually never come across this page before.
Yeah.
I'll have to give them a follow.
Yeah, they're good. So person of the week, Skeptical Physio. Post of the week, Adam Meakin's leaving the profession. Our injury of the week. Anything else to leave the lovely listeners with?
I don't think so. Have a lovely week. Have a lovely listen to part 2 with Dr. Taylor Goldberg, and we will be chatting to you next week.
Yeah, we'll speak to you all next week. See you later, guys.
I suppose then, without the access to imaging, or as sort of readily available as it could be, then you get really good at your clinical assessment. So let's talk about that a little bit. What is the typical assessment that you're doing with people?
Yeah, so first is subjective and just asking questions. So there's a really, really great paper by Leslie Russett. I can send it to you guys. It has a list of symptoms, and it has a chart that you can just check off, and the amount of those symptoms can be diagnostic for mild and moderate. Again, for severe, you're going to need imaging. But if we're talking about mild and moderate, we can do it based off of symptoms and some other orthopedic tests. But so symptoms is first frontline. And then after, there are different orthopedic tests that can help us rule in and rule out, but the validity of those tests are not the greatest. So taking symptoms and your orthos and objective findings both into consideration. Is that like the Baton score? Is that
really what you're going through, or
No, so that would be so the Baton scale is for just generalized joint hypermobility. For upper cervical instability, it's going to be completely different just for the cervical spine. And it's going to be a lot of neuro stuff too. So a lot of neurological testing in general, and then some upper cervical specific orthopedic tests. But no, the Baton scale is more just for generalized joint hypermobility.
And is that typically what you are using when you are assessing the generalized hypermobile person?
So that's what I'll do first. And there's a lot of limitations with the Baton scale. And so we should go over like just the HEDS diagnostic criteria in general. So if you look on Google HEDS diagnostic checklist, you'll see a checklist. And as musculoskeletal providers, we can do the first two criteria. The third, you will have to send to a geneticist for. So the first is the Baton scale. If your patient does not pass the Baton scale, that does not mean they are not hypermobile. If they are presenting to you and you think that they're hypermobile, or they think that they're hypermobile, but they don't pass the Baton scale, there is like 13 other different scales that you can do. The Baton scale only tests 9 joints. We have a lot more than 9 joints in our body. It's also extremely upper extremity heavy, not lower extremity heavy at all. It doesn't even test ankles. So there's a lot of limitations to the Baton scale. Then if they pass the Baton scale or another type of hypermobility scale, and I can give you guys a list off the top of my head. My second go-to is the 5PQ, and then there's a bunch of others.
Is that more lower limb focused? Was there one that's more lower?
There's a lower limb hypermobility assessment scale.
Yeah.
That's another one.
Cool. Yeah.
There's awesome. A lot though. Yeah. There's a lot. And then the second part of the criteria is there's 3 different categories for this, and you need 2 out of the 3. The first is a bunch of systemic questions. And then the second is if a family member has it. And then the third is basically if you're in chronic pain. And then if you pass both of those sections, you go to a geneticist to rule out all the other forms of EDS and any other connective tissue disorders and any other possibilities like rheumatoid arthritis, things like that. And if those are all negative, then you get a diagnosis of HEDS. Okay. Like I said at the beginning, that's how it's done right now. Once the HEDS gene comes out, this is all going to change.
Yeah. Is it expensive to go to a geneticist?
No, you can actually go to Invitae in the States for about $200.
Oh, that's good.
So yeah, no, it's not.
Yeah. And so what discipline, and I'm going to, once I hear your answer, I'm going to try and relate it to what it would be in Australia. What discipline do you find you're referring out to the most? Like I think you mentioned, like obviously people for more genetic testing, but just the people that want to, I guess, have the strength and the resiliency throughout their daily life. Is it physical therapy? If it's yourself, where they've seen you and you've helped them with this, they're like, great, now you need to go and see someone else in that you can see physically in the gym and that kind of thing. Is it, physical therapy or PT, or who are you using the most?
Yeah, so it depends on their goals. I mean, I kind of take the rehab role, so I'm very comfortable and confident in the rehab space and in the strength training space. I would say, honestly, like GI, neuro, those are the 2 most common I refer to. For pain specifically, for musculoskeletal pain, like that's what I do. So I don't really refer very much for that, but sometimes I will co-treat and have in-person PT and we work together. That is common, but I would say GI and neuro are the 2 most common that I refer out for.
Yeah. And you mentioned before that you, with what happened with upper cervical and having the manipulations, like, is there much role for manual therapy in this whole umbrella term of hypermobility? And that can be, things like manipulation, massage, needling, all those kinds of things.
So my opinion on manual therapy is kind of the same for the general population as it is for hypermobility, minus one thing. And so in general, if you find value in manual therapy and if you know that it is providing short-term relief, I think there is huge value in that. But you have to know that it is not changing or fixing you. The role of manual therapy for hypermobility, getting short-term relief can sometimes be game changing when nothing else can provide relief for you. So if it is safe and it is not an HVLA adjustment, and it's giving you that short-term relief so that you're able to do your rehab. You're able to get back to the quality of life that you wanted. You're able to do more in your life. I'm all for it. I think there's huge value in that. I also think that there's a huge value in learning how to do some of that stuff on your own, like self-management strategies and self-massage strategies, so that you don't have to rely on a manual therapy provider all of the time, because dependence is a real thing, and we want to avoid that.
Yeah. Okay.
And what about adjuncts like aids and assistive devices, orthotics, things like that? What role do they play?
Yeah, so I'm a huge fan of mobility aids, and I think that might be a little controversial for some people, but in my opinion, if say you have dysautonomia and you're scared to leave your house because you're scared you're going to pass out, but now you have a rollator with a chair that you can sit at any time and you're less afraid to leave your house now, how do you say that that's wrong? The argument is that they're going to atrophy and they're not going to get strong enough. People aren't going to get strong if they don't do anything either, if they're too fearful to move in general. So if these mobility aids are going to help them be able to do their rehab, to gain quality of life, gain independence, I think it's great. And I'm a big fan of it. Now, I think there needs to be rules around it, and I think it doesn't need to be 24/7, and there should be a goal that one day we are not so dependent on them if we are currently. But I think it's a great starting point, and I think it can really help a lot of people gain independence, and that's huge.
Who's making the decisions around devices over there? Is that like, are you calling the shots there, or is that a doctor or someone else?
As a virtual coach, it's not me. If I was as a chiropractor or a physical therapist, it could be, but I would say more orthos, more MDs are making the shots and going to be fitting and all of that stuff. Physical therapists might be able, I think it depends on your state, honestly.
Yeah. A colleague of mine that I work with at the university, I saw that, I didn't even realize, but he follows you on Instagram. He's just about to finish, or maybe he has finished his PhD looking at hypermobility and orthotic care. And not going to give too much away because I know it's being published very soon, but some pretty positive outcomes. And being a podiatrist myself, I guess the controversial part in our profession is giving out orthotics or mobility aids when people are asymptomatic. If we know people can adapt and become more resilient, we probably shouldn't be doing that. But it's very hard to research as well. But people that are hypermobile, just off my experience, nothing to do with it, the research is people generally feel better with some support underneath their feet, and they can do more, even in the sense they don't have any pain, less fatigue. They're able to feel like they can do more on their feet, that kind of thing. I mean, what do you think? And purely, just your opinion for an asymptomatic person that's hypermobile or HEDS having orthotics and not having any pain?
Yeah, it's a really good question. I also have a question for you on orthotics in general, but I would say if you're asymptomatic, I would go with no until you become symptomatic, because in my opinion, these mobility aids and orthotics should be used to help you through the symptoms so that we can build you up over time and gain independence. But my opinion on orthotics, and it could be totally wrong, is that they're not supposed to be used forever. They're only supposed to be used to get you to the point that you can build those muscles back up, and so that you can create that arch again. Is the
completely agree. I mean, we talk about like the nuances. There's those small percentage cases like post-operative, they've had things fused, car accidents, or people with adult acquired flat feet where they've done everything else, and that might be like 5% of all the people that we see that probably need them, not forever, but generally the longer term. But the majority of people, we kind of use them and think of them, explain them like Panadol for a headache, where you have Panadol, once the headache's gone, you don't keep taking the Panadol. Similar with this, once the symptoms are gone and we've built your resiliency, we don't end up, having the orthotics forever. What I've found is people, and it's always, I guess, the nuance in patient-centered care where they're like, I just feel better with them if we've used them in the short term. For say someone with some cranky arch pain, like, I've used these inner soles, I'm doing the rehab and doing the strength training. They generally use them for the longer term. They're like, I'm like, you can probably come out of these now. We can start to bring you out of them, but they feel better in them. And then in the long term, sometimes they come out of them, sometimes they don't. But I generally find, and this is what I hope the research is going to show eventually, and it's always their decision, but I generally find that people feel better in them as long as we've given them the right information. Like, you've got the strength to not be in them, but if you feel better, I'm not going to be the person to tell you no. But in the most cases, yeah, it's short to medium term, just like Panadol.
Like you mentioned that in a hypermobile person, you said they're asymptomatic, but then they're fatiguing earlier. So then wouldn't that be symptomatic?
Yeah.
Like that would be a symptomatic
Yeah, I
person.
guess so. Yeah.
Like when you say,
So I say symptomatic when I mean pain. Yeah, like they don't have any pain,
That's
but they're like,
yeah, I was gonna say it's tricky to define asymptomatic, but I
Yeah.
would put fatigue under symptoms. And
Yeah.
like when I'm talking about asymptomatic hypermobility, I just mean like you can see that they're clearly hypermobile. They
Yeah.
got no symptoms, no pain, no fatigue, no issues. Like,
Yeah, okay. I should have clarified that. And the example is they like put on a pair of shoes, just a very simple pair of supportive shoes, or I'll just put some tape on their foot and go, great, just see how you go for a couple of weeks. And they come back and they're like, I felt so much better just with this little bit of tape or this supportive shoe. And I'm like, okay, yeah, there's fatigability and things, and it's not inherently your fault that you're weak or anything like that. It's just these things can contribute to that. And let's use this in the short term, do the strength training, do the resistance training, and over a long enough period, if you feel comfortable, you can come out of them, but it's completely up to you. And if it's helping you have a higher quality of life, then I'm not going to be one to say no, but as long as I've given you all the education to think about it. But you're right, it's so tricky because then on the other side of the spectrum, we have people that just give orthotics for everyone. Like, great, you've got a flexible foot, you need an orthotic and you have it for life. And that's not right. And that shouldn't be the case either.
yeah, and like what's your opinion on for that situation? They have a flexible foot and they have orthotics forever. Do you find long term that they are ending up in more pain because they're not doing the things they need to strengthen their foot? Or what do you find in those situations?
Yeah, I do say that. I certainly say, and it was like you were saying before, the dependence on them. And you can get caught, and I've certainly been caught, not so much now because I'm aware of it, and I've been burned in the past where someone will come in and I'm excited to say, hey, we might not need these. You don't need to go and spend $800 every year on a new pair of orthotics. You may be able to build your capacity and strength, and they've not come back because I've just told them, hey, you don't need them, and that's something that's helped them. So it's kind of got to be a bit nuanced where these are the things we can do, and it might take a couple of consults, but let's work on your strength. And if you want them, that's fine. If you don't, that's fine as well. So it is really quite tricky because you can't not validate how someone feels when they have it in, because they might feel better, like, I'm happy to do this because I love them. But then also it's like, do you love them because you didn't have any other awareness of the other things that you could possibly work on yourself?
That makes sense. Yeah.
Hmm.
Makes sense. Yeah, let me know when that paper comes out from your friend too. That
Yeah,
sounds
I
really
will.
when we're talking about joint pain, potentially due to hypermobility, do we know what is driving that pain in some senses? Like, is it muscle fatigue, or is it the joint itself that's just not coping with those extremes of ranges? Like, or a combination, I'm assuming, is going to be the answer of it all.
a combination. What
Yeah.
we most commonly see is that when your ligaments aren't able to provide support to a joint, those muscles have to be on more than they should be, and they work harder, and therefore they fatigue easier and they get really, really, really tight. And that can be one. Another thing is if you are hyperextending and you're like leaning when you're standing constantly and always loading in that hyperextension end range on like your elbows or your knees or your hips and your ankles, that can be another thing that your joints don't love.
Yes, there's lots of behavioral change stuff then, because that's probably something that they've just done forever. Well, that's something that I often see in the clinic, those hypermobile knees, and they're always just standing in a very hyperextended locked position. So it's a lot of cueing just to, as you mentioned before, soften the joint.
Yeah. And the thing with pain too, and I think this is really important, is it's never just one thing. Pain's multifactorial. I'm a big biopsychosocial girl, and life has a huge impact on our pain, and our mindset around pain has a huge impact on our pain. And so really taking the full picture and the full person into consideration when you're thinking about pain, I think is really important.
Are there many, or do you see many people that are medicated for this? Like, are there any medications that help, or that's kind of, I mean, that's obviously the physician recommendation, but do you see any that have helped, or common ones that people may come across?
Yeah, so I'm not an MD. I have no
Yeah.
formal education on this stuff, but from my experience, interestingly, a lot of hypermobile bodies don't do well with certain medications. Opiates is high on that list. We also know that local anesthesia doesn't work as well on hypermobile bodies. So there are some in that realm. Muscle relaxers can be kind of do the opposite of what you want because you need your muscles to be strong and not relaxed. Botox would be in the same kind of realm as muscle relaxers. As far as like dysautonomia and MCAS, they have their own slur of medications that can be really, really helpful with that. I don't know much about those type of stuff, but if we're talking about like pain management medications, I would say I see more things that don't work than do work.
Yeah. Yeah. Okay. Interesting. Do you see like people have like cortisone and PRP and injectables and things like that? I'd
So
imagine it wouldn't be indicated based off what you're kind of saying in many cases.
they're doing a lot of studies on Prolo right now, and they haven't found any positives research wise yet. That might be changing soon. It might have already changed, and I might be speaking a little bit outdated, but I know there's a lot of studies going on with Prolo right now for hypermobility, especially for upper cervical instability. As far as steroid shots, obviously they give them out like candy here, so most people have tried them. Like anything else, it works for some people, doesn't for others.
Yeah. Yeah. And talking about kind of children, and you kind of touched on it before about kids being more clumsy. How often do you find or hear where it's not just, oh, they're growing and changing, they're clumsy, that's fine, that's just kids, that's how they are, compared to, no, there's actually something systemic happening with them. They need, further aggressive, don't want to say aggressive, but they need more treatment and need more information and education. Do you see that quite often?
So I don't work with kids at all, so I never see that, but I can say from my own personal experience, when I was a kid, I wasn't able to hold a pencil until second grade. And so there was some developmental things that they saw as a kid. I didn't have good reading comprehension. I had to go to occupational therapy as a kid, and I didn't like meet my developmental milestones. So I think that is something to look out for in kids. We also know that kids naturally have more hypermobility. And so the Baton scale is 1 point higher for kids. So it's really hard to tell if your kid is actually dealing with hypermobility or if they're just extra bendy because they're still super, super young. So really looking out for developmental delays, and then any systemic stuff like GI stuff. Are they having any issues going to the bathroom? Things like that, I would assume. But again, I do not work with kids, so I don't fully know that answer.
Yeah.
I had a question, we touched on it a little while ago, but we were talking about subluxations, and I was wondering how much of that do you think is that subjective feeling of instability in the joint versus them actually subluxing?
Yeah, so there's a huge difference between medical subluxations and chiropractic subluxations. So chiropractic subluxations is more of that feeling of something's off, something's out, something's misaligned. Yeah, all that stuff. And as a chiropractor, I don't use that word subluxation to define any of that because I think it makes things really, really confusing. Medical subluxation is when it truly does come out of the socket and come back in. And as someone who experiences shoulder subluxations now only like 3 times a week, which is pretty exciting, but it is it's coming out. You can hear it, you can feel it, you can see it and coming back in. So medical subluxations, if you know the signs and symptoms to look out for, when you're experiencing one, whereas the chiropractic subluxation, not so much.
And how do you ask or question a patient about that without giving off a sense that you're doubting them, I suppose?
Yeah, definitely. So the biggest things is have you ever had any feeling of like heaviness in your arm or your leg, almost like a dead leg, and like that arm was harder to use, maybe after you heard a clunking in that joint? Have you ever actually felt your joint fully come out and come back in? And did you hear any noises with that? You can also do apprehension tests on these joints to see if that is confirmed or not.
Yeah. I've had patients before that have told me that they sublux their hip joint, and in my head I think of the anatomy of the hip, and I just think that must be so hard to sublux the hip joint, and I just haven't been able to find the words to question it further without feeling like I'm questioning if they're being truthful or not. I don't know if that makes sense.
And believe it or not, hips are actually really easy to sublux if you are hypermobile. You see it every single day, but trying to ask more, like feeling the hip, and you probably can sublux it if it is somebody that has had like if you were to touch my shoulder right now and do an apprehension test, it would come out. And so it doesn't always have to be those levels of extreme, but that is a good way to kind of see what's going on.
What about like positionally for certain joints? So for example, if we go back to the hip, is it typically in a particular position like external rotation or internal rotation or something like that where it's more likely to sublux, or no?
Both.
Any? Yeah.
And I think that there's a lot, like hip dysplasia is really, really common in EDS. And so that's something that I think more clinicians need to learn about and understand, because we were only taught about it in kids for like one lecture. But with hip dysplasia, it's very, very common for them to have subluxations and dislocations in their hips.
And are you finding, for someone like yourself and the people that you're seeing, are you recommending resistance training and movement as kind of something they need to do for the rest of their life? Because we talk about things as short term, like, hey, you've only got to do this amount of work for this long, because we know exercise compliance is one of the barriers to people doing it for a long time. And we know doing it for a long time is really good, but you're recommending that, this is something that you have, and these conditions and the flexibility that you have isn't going to go away, is probably something you need to do for your life.
Yeah, 100%. That is one of the hardest conversations to have as well, is that this is something you will have to manage your entire life. You don't get to take a break, unfortunately. And I'm a big fan of, so let's try to make it enjoyable for you. What do you like to do, and how can we make strength training more fun? I am a huge fan of making exercise fun. And I think it's really important when it is something that you genuinely need to manage your condition. Let's make it enjoyable. Let's find ways to make it enjoyable and hold yourself accountable. Let's make dopamine hacks. Let's habit stack it. All of that stuff I think is really valuable.
Do you recommend people to do, I think, one of the things that I find that works well for people is in that group setting, as the extreme example of like CrossFit or group strength training or Pilates, that kind of thing. Do you recommend people do a group setting and then hoping that, and I guess educating and having conversations with the people that are running those group settings? Hey, example, Kelly is hypermobile. These are considerations we've put in place, but she needs to do this. Are you recommending that, or what's kind of your go-to?
So I actually recommend it to the patient more than I would recommend it to, because I'm not going to know who's teaching the class.
Oh yeah. So that's to the patient.
But having them know, okay, if you're in a yoga class and they're staying in a position for 3 minutes, you don't have to follow that. If they are doing some, like whatever, that's just an example, but making sure they're comfortable modifying in that class, I think is really important. A lot of the time when you're in a group setting, you like to conform, you don't want to be different. And if you're not going to be comfortable or able to modify for your needs, I'm not going to recommend a group class. You have to be confidently able to listen to your body during those classes, and not everybody is at that point, and that's okay. So there are a lot of amazing virtual hypermobility group classes out now. I know Physio Elements has one. I don't know many off the top of my head, but there's a lot of opportunities like that I would recommend before I would recommend just going to any group class. But if it's something that they enjoy and they're confident and able to modify themselves, then yeah, I'm all for it.
Yeah, great. That's really good to hear. Good.
Just on the hip dysplasia topic, again, quickly, moving back to jumping around a little bit, but Is when you talk about hip dysplasia, are you talking about when they're born sort of hip dysplasia, or hip dysplasia when they're older?
Older is what I'm
Okay.
talking about. And so the hip socket itself is very, very shallow, and they might have had it since they were born, and it may have gone unnoticed. And I see that quite often. And hip dysplasia is a very long diagnostic journey and a very long healing journey, especially if you do end up getting a PAO. So yeah.
Yeah, I had a patient with Down syndrome actually who had hip dysplasia. He was 15 and ended up having to have surgery. It was so hard because he was nonverbal. It was tough, really tough. What would be some of the key findings in someone with hip dysplasia? Like, what would you be looking out for in an older patient?
Yeah, so females, it's more common in females in general, and then like flexible type females, but pain that isn't going away, if they've had pain forever and they are really, really strong, it's probably not their hip flexor. Like I hear all the time, I was told my hip flexor, and these are cheerleaders and gymnasts who are able to hold freestanding stretches. Like it's probably not their hip flexor. If they're really strong and they've been in pain for a long period of time, do a little bit more digging and get some imaging done.
And an x-ray should show that, right? Yeah.
100%. Yep.
Yeah. Wow. Cool.
Yeah, great.
Do you have any?
No, that was good. Well, it was very systematic. It was perfect.
I don't know. Really I feel like we were all over the place, but
yeah, it was good. I was just I was looking back and I'm like, we're kind of answering these questions as we go through. It was really good. So yeah, thank you so much for coming on and finding the time. It's incredible to think that we can do this. We're in Australia and you're all the way over the other side of the world.
I know, it's so cool. I think that's like my favorite part about social media is that we get to all learn from each other and grow as clinicians, no matter where we are. It's pretty cool.
Yeah. Now, for people to find you, patients as well, because we have patients that listen to this, it's mostly clinicians, but for people to find you, you've kind of got the best of both worlds. You do clinical online stuff, but then also you've got clinical education for clinicians as well. Is that right?
Yeah, so you can find me at the Hypermobile Chiro, hypermobilechiro.com, on Instagram and on TikTok as well, and now on Threads. That's the newest social media.
How are you finding that, by the way?
I'm loving it. I'm the type of person that likes to just type my thoughts away, so I'm a big fan right now. We'll see, but I like it so far.
Yeah.
What about you guys?
Just Instagram, and I had a bit of a play with TikTok, but because I work at uni and then work clinically, I don't have the time. I should be able to just conform it and then post it everywhere, but just Instagram for now. But I'll certainly give you a follow on TikTok and Threads.
Yeah, definitely. And then for clinicians, Clinical Concepts is a mentorship that I do with another doctor, Dr. David, and it is for chiropractors specifically to learn how to treat in a more evidence-based manner and how to use technology in practice as well. So that you can do some more hybrid or virtual stuff. So you can find us at Clinical Concepts on Instagram.
Yeah,
that's
good.
Cool.
Yeah, awesome. Give that a share. Lovely. Any advice? If you give one piece of advice to anyone, what would it be? And even to yourself when you first graduated, like what would be your advice then and kind of now?
Yeah, my biggest advice is put yourself out there. DM the people that are doing the things that you want to be doing. Everybody in this field, I have yet to meet someone in this field who doesn't want to help and who doesn't want to help you grow. It's scary, but send the DM. That's networking now. Send the DM, post on social media. Nobody's thinking about you more than you're thinking about yourself, and you have no idea how far it might take you. So get over the fear, get over the imposter syndrome. We all have it. It's not going away anytime soon. Do things scared.
Yeah, that's I
great
can
advice.
imagine,
like
a picture of you and then just like the Nike tick almost of like send the DM. Just do it. Send that DM.
Just do it. Send the DM.
Okay.
I love that. I might make that. I love that.
Yeah, that's good.
Awesome. Well, thank you so much. I got heaps out of that, and I'm sure everyone listening will as well. So thanks so much for taking the time. Enjoy your Saturday night in Colorado Springs. And yeah, we'll probably have to get you back on the podcast when this research comes out about this EDF gene.
Yeah, I will keep you guys updated. Yeah, please reach out again whenever, and enjoy your Sunday, which I still think it's crazy that it's different days right now.
Awesome. See you later, Taylor. Bye.
All right. Bye.